This is Dr. Nathan Selden from Oregon Health and Science University, Department of Neurosurgery, on behalf of myself, Dr. Raskin, and Dr. Litvak on split spinal cord malformation. The purpose of this chapter is to identify the urological, neurological, orthopedic, and cutaneous manifestations of split cord malformation, which is an occult spinal dysraphism, to describe the embryology of split cord malformations, to list the key imaging findings according to the PANG classification schema, and to formulate appropriate goals for surgery in the case of PANG type 1 or type 2 malformations. Split cord malformation was first defined in the 17th century and has been called diastomatomyelia, sometimes still used to refer to PANG type 1 malformations, diplomyelia, sometimes still used to refer to PANG type 2 malformations, or simply split cord malformation or split spinal cord. PANG type 1 malformations are characterized by a bony septum cleaving the spinal canal into duplicated thecal sacs, each with a spinal hemichord. Type 2 malformations are characterized by a single dural sac with a cleft duplicated spinal cord separated by fibrous midline bands tethering the cord to the dorsal dura. In both types of malformation, distal tethering is also very common, typically in the form of a filum terminale or other fatty malformation, or even duplicated fatty phyla terminale. Both types of malformation may also occur together with other types of dysraphism, including myelomeningocele. Split cord malformations represent approximately 3.8 to 5% of all congenital spinal anomalies, with an incidence of 1 in 5,000 live births. The rate of split cord malformation, unlike myelomeningocele, is unaffected by gestational folate supplementation. There is a slight female predominance of 1.3 to 1, and a bimodal age at diagnosis, typically between 4 and 7 years or 12 and 16 years. Type 1 malformations may be more common than type 2, although the stigmata and neurological and skeletal effects of type 1 malformation are also easier to discern, making this distinction somewhat complicated. Split cord malformation is thought to occur as the result of neurenteric fistulization during gastrulation, in other words, a ventral embryological defect, which is therefore often associated with split or cleft of the vertebral body at the level of the split cord malformation. In general, meninx primitiva invades this fistula, induces formation of a bony septum, which separates the two hemichords into separate dural sleeves in type 1 malformations, or a fibrous septum separating the two hemichords within the same dural sleeve in type 2 malformations. A number of associated anomalies can occur together with split cord malformation, listed here in order of prevalence, including scoliosis, thickened or fatty filum terminale, neuroorthopedic syndromes, the presence of a syrinx, myelomeningocele, other terminal lipomas, or Chiari malformation. Symptoms and signs of split cord malformation are listed here on the right and include pain, neurological and urological deficits, skeletal abnormalities, various cutaneous markers, and other associated findings on standard neurological or more advanced neurological and urological examinations. Shown on the left are the cardinal feature of split cord malformation, involving a prominent patch of hypertrichosis, sometimes with a central area of atretic or waxy skin, often referred to as a cigarette burn. Other dysraphic markers may be present in the same patient, such as a distal sacral dimple shown in this patient associated with the distal lipoma in figure B. The imaging features of split cord malformation are detailed in this table. Type 1 split cord malformation is more likely to occur in the lumbar region, and type 2 anywhere along the spinal axis. CT is particularly helpful in detailing the bony spur and other bony anomalies that are seen in type 1, and MRI is particularly helpful in imaging the spinal cord and other parenchymal abnormalities that are present in both types of split cord malformation. Various imaging features of split cord malformation are illustrated here. On the left is a sagittal T2 MRI demonstrating hydromyelia of the spinal cord just cranial to a large bony spur in the midline of the spinal canal associated with the split cord malformation. A very substantial bony spur and other vertebral anomalies are shown on an axial CT in the middle image. The right image demonstrates severe scoliosis and vertebral anomalies and congenital fusions, as well as dysraphic anomalies associated with the split cord malformation of the mid-thoracic region. The goals of surgery for split cord malformation are to release central nervous tissue from any tethering elements, including fibrous or bony septa, as well as transecting thickened or duplicated phyla terminale or other fatty malformations distally. Most patients therefore undergo detethering both at the level of the split and of the terminus of the spinal cord in a thickened lipoma or fatty malformation. Most split cord malformations are operated on after discovery, although some experts will observe in particular type 2 malformations if there is no evidence of neurological, urological, or skeletal compromise, refractory pain, or other significant problems for the patient. Complications of surgery for split cord malformation include transient urinary retention, cerebrospinal fluid leak, surgical site infection, occurrence of a new sensory or motor deficit, which may be transient or, in a small number of cases, permanent. In general, the natural history of untreated split cord malformation is felt to be worse than the complications resulting from surgery. Surgery for split cord malformation improves pain in the vast majority of cases and is very likely also to improve or eliminate sensory deficit, motor deficit, bowel and bladder dysfunction, and to ameliorate and improve the treatment of and also increase the treatment safety for scoliosis. Importantly, late reoperation for retethering is not uncommon and is one potential downside of initiating a course of surgical intervention, which is why some experts advocate for observing, in particular, asymptomatic type 2 split cord malformations. Nevertheless, upon discovery, most malformations do undergo surgical treatment. To summarize, split cord malformations develop during gastrulation around embryological week 3 due to the presence of a neuroenteric canal or persistent connection between the ventral endoderm and the more dorsal neuroectoderm. The Pang classifications separate split cord malformations into type 1 with a bony septum separating 2 dural sleeves, and type 2 with 1 dural sleeve and 2 hemicords contained within it, generally separated by fibrous dorsal bands. The goals of surgery include untethering of the spinal cord at the level of the split cord malformation, including removal of any bony or fibrous spurs, as well as distal untethering of fatty malformations or thickened or fatty phylum terminale. Long-term functional outcomes following untethering for split cord malformation are generally excellent, particularly when benchmarked against the natural history of this disease in its untreated state and even against other types of complex spinal dysraphism.